Okay, so everyone can hear me just fine?
Yes.
Okay, wonderful. So thank you for that wonderful introduction. Again, my name is Yvette Aidoo-Forson, and I'm happy to be talking to you today about wound management. Um, so my practice has focused on patients with complex wounds and those with bowel and bladder disorders. I am certified, board certified in my specialty, and I recently joined GDNA and encourage others to do the same given the important mission of ensuring quality care in our homeland of Ghana and our commitment to supporting nurses both in Ghana and throughout the diaspora. So with that, we're going to go ahead and get started. And so at the end of this course, I hope that you'll be able to discuss different wound types and why etiology matters. And then we'll jump into what exactly makes a wound chronic. There has to be a difference between an acute wound and a chronic wound, and we'll talk about that. And then we'll discuss some of the requirements necessary to promote healing. So when you think about all the wounds in the world, they generally speaking fall into one of these major categories, whether it be a diabetic, traumatic, pressure-related injury, arterial, venous, or surgical. You'll notice that in the center of the slide, there's a question mark, and I'll come back to that in a few minutes. But just note that most wounds do fall somewhere within these categories. Now, when someone has surgery, we know why they have a wound. They had surgery, right? So I'm not really focused on acute injuries. My focus is on chronic wounds because very often they have more than one causative factor. So for instance, you may have a patient who sustained an injury, stepped on an object, they come in to see you, you do the usual, you do a basic assessment, you irrigate the site, you provide antibiotics, a tetanus shot, and you send them on their way. But then they come back a few weeks later and they have a presentation similar to what you see on the screen. This is where the investigative work kicks in. Why didn't the wound heal the way you thought it would? And it's only upon doing a thorough assessment that you notice a few other things, such as deformities associated with the foot, callus formation, neuropathy, perhaps the skin is excessively dry. And if you are skilled enough, you'll be able to put two and two together and immediately suspect diabetes as the causative factor. But that only comes from doing a thorough assessment. And we have very good reason to be concerned about diabetes because I actually was just reading an article recently on the World Health Organization website, and right now in Ghana, there are about 2.4 million people living with diabetes. And I severely suspect that this number is underreported because when we look at worldwide figures, there are actually 240 million people living with undiagnosed diabetes. So what this means is that if you have a wound that is failing to respond to your treatment despite your best efforts, you should consider diabetes as a causative factor, especially in today's environment. Overall, worldwide, there are 537 million adults living with diabetes. So again, a key takeaway is that diabetes is really just such a problem when it comes to wound care. And when we take it a step further, we see that across the globe, when we look at continents where diabetes is exploding, I even circled it here, Africa is the continent with the highest growth in diabetes, okay? 134%. So that's staggering. And again, this should factor into how you approach wound care. So complicating things further is that you can have a patient with a venous insufficiency wound who has an arterial component and also has diabetes. So what this means is that your care plan must include ways or strategies to address diabetes, circulation, and edema management. Talk about complicated, right? So this is why our wounds are not doing well today. There are so many things going into what makes a wound chronic. So when I say chronic wound, what does that mean? What that means in the wound care community is a wound that fails to progress through the wound healing cascade within roughly a 30-day time frame. So acute wounds, such as ones related to surgery, usually within 4 weeks or so, we're done. But a chronic wound will hang out longer than that. And again, this requires an investigation to determine why. Here in the United States, approximately 2% of the total population are estimated to be affected by chronic wounds. And by my math, that's about 6.6 million people here in the United States. And this number is expected to rise as the population becomes older and as comorbidities continue to plague our population. So you'll remember that a few slides ago, there was a box with a question mark there. And the reason for that is because besides those major wound types, there are other reasons for delayed wound healing. You may have a patient with an autoimmune disorder. Here in the United States, autoimmune diseases such as Crohn's disease are very, very common. And so in particular, there's a wound known as pyoderma gangrenosum. And that wound presents very similarly to what you see on your screen. The reason why that diagnosis is important is because it greatly affects how you approach wound management. For instance, sharp debridement would be contraindicated. So again, etiology means everything. Vascular diseases such as sickle cell. So patients with sickle cell disease, we understand that disease process. I've had young patients where because of sickle cell, they develop wounds to their lower extremities. Tends to be quite painful. Again, that's a causative factor. On occasion, we'll have a patient with a cancer or a fungating wound where the tumor actually emerges through the skin. And so it has a presentation almost like cauliflower or a rocky appearance. Usually odor is a big issue. And normally with these type of wounds, healing is not the goal. It's more so about comfort and odor management. And lastly, we may have moisture-related skin lesions. So think about patients who are incontinent of urine or stool. All of this can contribute to poor wound healing. And by the way, if you've been managing a patient to the best of your abilities and the wound is not responding, you should consider a biopsy. Because again, the causative factor may not have been correctly identified, but a biopsy can point you in that direction. So again, that's why etiology matters. But we're going to now talk about the wound healing cascade. I've mentioned the term a few times already, and this is key to your wound management strategy. So what makes a wound chronic? So if we look at the image to the left, we see a wonderfully healing wound. The wound bed is red, granular, it's contracting down nicely, versus the image on the right, which has, you can tell that this patient has had this wound for a while. The wound bed is not looking healthy. It's a lower extremity wound. And so why the difference? Why is it that you have wounds that heal quite well and some that do not? Well, that has to do with something called the wound healing cascade. When you have any wound, all wounds must go through the wound healing cascade to be considered healed. So it's 4 phases. When you have a surgical procedure and the skin is cut through, that starts the first phase, which is the hemostasis phase. So you'll have bleeding initially, which is normal, but due to platelets, you have coagulation. And so that usually is managed quite well. But then the body immediately jumps to the inflammation phase. Again, this is normal. And so this lasts on average a few days, 4, 5, 6 days. And this is your body's natural response to a break in skin integrity. So you'll see redness, pain, warmth, tenderness, all normal because your body's white blood cells are doing its job and mounting a defense against potentially harmful pathogens. And for most people, this happens without incident. Then we move on to the proliferation phase, which should be only about a few weeks. And so during this phase, this is where the work begins because you have collagen fibers being developed that help to fill the wound with granulation or scar tissue. And then lastly, wound healing concludes, and it can take up to 2 years actually for this to be complete. So when you see that initial resurfacing of skin, just know that your body is hard at work. If you think about kente cloth and how it's woven, collagen fibers do something similar so that the work still continues even when there's a scar present. For that reason, you need to be very careful with wounds that have recently healed. And the skin is never as strong as it once was. Once you have a scar, it only achieves about 80% of its original strength. Again, this is important to note because you have to protect that area. So you'll notice that the inflammation button is where you're seeing that red, I have it blinking. The reason for that is a wound that is chronic fails to go through these 4 phases as listed here. And 99.9% of the time, it is because it is stuck in the inflammation phase. So a phase that should only take about a few days lasts for weeks to months to years. And it is important to note that chronic wounds don't actually start with hemostasis, they just sort of develop. So when we think about pressure injuries or diabetic ulcers or venous wounds, they just develop. They don't go through the hemostasis phase as is the case with acute wounds. This, I'm going to pause for effect. This is the reason why wounds are chronic, because they fail to go through these 4 phases, and they tend to be stuck usually in the inflammation phase, okay? Again, it's a whole complicated conversation, but just know that when a wound is stuck in the inflammatory phase, there are inflammatory proteases and cytokines that linger in the wound, keeping this wound angry. So even an acute wound that started off well can end up chronic if not cared for properly, okay? And this can last, again, from weeks to months to years. And so the reasons for that are extensive. You can see here, we talked about diabetes, but there are so many factors leading to a chronic wound, such as age or poor circulation, poor nutrition, but we're going to focus on poor wound care in this presentation. So here is a picture of a wound that we don't like to see, okay? So we hate this type of thing because it has everything wrong with it. It has everything wrong with it, including erythema, necrotic tissue. It's clearly infected, odor. I can smell it through the screen. As a matter of fact, that's how bad a wound like this can be. And when we see this, we know that it's stuck in the inflammatory phase. And in fact, in this case, it's clinically infected. But it's important to note that not all wounds that are stuck present that way. Sometimes they present exactly like how you see it on the screen. So it looks innocent enough, but the wound is stuck in the inflammation phase. And sometimes the only way you'll know that is because it simply never heals. It never progresses. So when you see that, you need to know that there is a problem and you need to take action. So we're going to talk about the local wound environment and strategies to promote wound healing. And so what do we need in wound care? We already know that there are intrinsic factors with a patient that we can't necessarily control, such as age or perhaps medications that they're on, but we can control how we treat the wound. So the essentials include cleaning and debriding, managing infection and or biofilm, maintaining a moist healing environment and providing insulation to a wound, managing dead space, and maintaining open wound margins. So every wound care plan should include a thoughtful process for cleansing. It's a matter of what you choose, and what you choose depends on how the wound presents. As you can see here, there are several options. Here in the United States, I will tell you that normal saline is very popular, and for good reason, because normal saline is isotonic, non-cytotoxic, it's safe, you don't have to worry about allergic reactions. For that reason, it's very popular. We also tend to use mild soap and water, particularly for our dirtier wounds. So think about pressure injuries, venous stasis ulcers, we use mild soap and water. And there's also commercial wound cleansers available. We do use antiseptics. I'll get into that shortly. So again, looking at this wound, it's clean, healthy, granular. Normal saline is sufficient. You don't need to be fancy. Normal saline is enough to get the job done. It's important to note that every wound should have some cleansing plan, because cellular debris remains in a wound, even a healthy one. And so it's just a good idea to clean it as a matter of protocol. So what happens when we have a wound that's not so nice? So we have a wound filled with what's called necrotic tissue, which is dead tissue. So you have eschar on the left, you have slough on the right, which looks almost like chicken fat. And so when you see this type of wound tissue, it's a problem because dead tissue serves as a harbor for bacteria. The wound will not progress as long as this necrotic tissue is present. So here's another example of a wound. You see here, there's actually two wounds. This wound happens to have slough, eschar. This wound here to the right is covered with a thin layer of eschar. Again, all unhealthy. You need to remove it. So debridement is the removal of non-viable tissue. That's what the term means. And your body actually does this naturally in the inflammation phase that we talked about. So remember that for a normal, healthy person, the inflammation phase is quite short, just about 5-6 days or so. And our body is equipped with cells, specialized cells, that can eat up bacteria and essentially clean the wound and debride it naturally. So when the body becomes overwhelmed and can no longer do it effectively, that's how you have the growth of necrotic tissue, okay? And so the debridement benefits cannot be stressed enough. It helps to reduce bacterial levels, helps with odor management, it helps to jumpstart the wound healing cascade that we talked about. It allows for an accurate assessment, and it can address other hindrances to wound healing, including epiboly, callus formation, hypergranulation tissue, which we'll talk about in a bit. So again, when we debride, what we're essentially doing is we're allowing the wound to be converted from a chronic wound to an acute wound. And so when we convert it to an acute wound, it has the opportunity to go through this wound healing cascade that we've been talking about. And it is important to note that for chronic wounds, you typically need to debride more than once. Usually serial debridements are required to achieve this effect. And there are different types of wound debridement options, which we'll talk about right now. So probably the one that people are most familiar with is mechanical debridement. So when we do a wet to dry dressing, we are doing mechanical debridement, which is taking gauze, saturating it with normal saline, making sure it's damp, putting it in the wound, allowing it to dry, and then you take it out dry. And in doing so, the thought process is you remove dead tissue. But there's a problem with that. You also remove good tissue. And also, it's very painful. And it requires frequent dressing changes. And it can cause lack of blood flow due to vasoconstriction because the fluid can be cooling to the wound and cause a decrease in blood flow. And there's infection control concerns. For this reason, wet to dry dressings have fallen out of favor in the United States. We do not do it often for this reason, okay? Next is autolytic debridement. And when you put a dressing on a wound, you're essentially doing autolytic debridement. You're relying on the wound fluid to help clean the wound. As I mentioned before, your body is equipped with white cells that help to debride a wound naturally. And so when you perform autolytic debridement, you're basically maintaining a moist healing environment, allowing for wound fluid to clean the wound for you. This is very common, and this is probably the most common way in which we do debridement in the United States. And so these are several dressings that help facilitate autolytic debridement. For this reason, the patient should have an adequate white blood count in order for this to be successful. Next is sharp debridement. And so this is literally taking an instrument such as a scalpel or a curette and chopping away at the dead tissue. It can be done in a hospital. It can be done in a clinic. You just need the right tools. There are some reasons why you would choose one method over the other, and we'll talk about that just in a minute. But just know that sharp debridement is your quickest option. And there are times where you need to act quickly when it comes to debridement. And then we have chemical or enzymatic debriding agents. So fluids, solutions such as Dakins, which is quite popular here in the United States. It's a bleach solution. Vash, which is somewhat similar. Santal, which I believe in the UK should be available because Smith & Nephew is the company that manufactures it. Silver nitrate sticks. These are all things that can help with chemical debridement. So if you look at this wound in front of us, this is a wound that definitely needs debridement. If you want to heal this wound, you must debride it first. Okay, we have eschar, we have some slough, and so you have some options available. You can do autolytic debridement by putting on a moisture retentive dressing. It's slow, but it can be done. We can also do a sharp debridement. If the patient is going to a clinic, they can use an instrument such as a scalpel or a blade and remove it right there on spot. Or you can do chemical dressings. So for instance, Dakins, as we just talked about, or Santal. But when you're dealing with a wound of this magnitude, okay, you need to do a surgical debridement. In other words, this patient needs to be in a hospital setting and debrided right away. And the reason for that is because you can see this erythema here telling us that this patient is at risk for sepsis if we don't act quickly. For that reason, the other ways of debridement fall to the wayside. We need to do a surgical debridement so this can be removed ASAP. Okay, so we're now going to move into managing infection or biofilm. And so for those of you who've never heard of biofilm, when you brush your teeth in the morning, you feel that slimy coating on your teeth. That is biofilm. For those of you who wear contact lenses, when you soak it in the solution and then you rub it to clean it, you are removing biofilm. Biofilm also exists in wound care. So think of biofilm as a gang of bacteria that is there to cause trouble. The problem with biofilm is that it's not as obvious as when you have an infected wound. Sometimes your only clue is that it may have a shiny, slimy appearance covering it. And that would be your only clue. And then also that the wound doesn't progress. So biofilm is just as much of a threat to wound healing as necrotic tissue is. The good news is that you can manage biofilm by debridement and also using these products that we just talked about, including Dakins, acetic acid, which is very effective against Pseudomonas infections. That's a vinegar solution. In the United States, silver-based dressings are very popular. Some would say we overuse silver here in the United States, but it has a broad spectrum effect, which would be part of the reason. And Vash is also very popular, which is kind of a cousin to Dakins solution. We also have iodine-based products, such as Cadexamer iodine ointments. Iodosorb is very popular here in the United States and is quite effective. We also have povidone iodine, so betadine. Now, a word of caution, here in the United States, we use betadine, but very sparingly. We don't use it often. And the reason for that is because as with most antiseptics, they are harmful to good cells. So once the wound bed is clean, you should stop using antiseptics because they actually inhibit wound healing. That is why betadine is not used for routine wound care. It is not. There is an exception to that. If we have a dry, stable eschar to a heel, we may use betadine to paint this and keep it dry and intact because although eschar is generally speaking a bad thing, it can be a good thing in this instance because it's serving as a protective barrier. If we disturb this cap, we've created a wound that probably will not heal. And so in this instance, we want to maintain the eschar, and some practitioners will paint it with betadine daily just to keep it dry. Now, a word about hydrogen peroxide. Hydrogen peroxide, we do not use it in wound care. In all of my years as a nurse, I have never used hydrogen peroxide on a patient. And the reason for that is because the studies are conclusive that hydrogen peroxide harms cells responsible for wound healing. And there's a risk for air embolism if you use it in deep cavity type wounds. So for this reason, hydrogen peroxide is not used in wound care in the United States. Really, I have never used it, and I have been in this for about 15 years. Okay, so that's just a word about hydrogen peroxide. I know it's very popular in patients, in people's homes because of the bubbling action. There's some sort of satisfaction associated with using hydrogen peroxide because we feel like it's doing something, but it is very, very detrimental to wound healing. So some tips for cleaning a wound: make sure you clean the wound and the surrounding skin. Protect the peri-wound skin if you're using harsh chemicals such as Dakins or acetic acid. Stop using antiseptics, as I just mentioned, as soon as the infection clears. Debridement can also address biofilm, and diabetic wounds can be infected, but they may not show the classic signs and symptoms because diabetes, we know that immune response is inhibited when you have diabetes. Okay, so now we get to moist wound healing and insulating a wound. So the thing about wound healing is that we need a moist healing environment. It cannot be too wet. It cannot be too dry. It needs to be moist. If you have a wound that's too wet, you now run into issues with what's called maceration. You see the white skin that's surrounding this wound. That's maceration. The dressing is saturated within hours. And you might also see something called hypergranulation tissue, where the tissue grows beyond the wound bed. Okay, all of that indicates that your wound is too wet. And when the wound is too wet, you need a dressing to absorb some of that exudate so that it remains moist. And so for that, you have a variety of options, including ABD pads, foam dressings, alginates, hydrofibers. They all absorb to keep the wound moist. On the other spectrum, if you have a wound that's too dry, that is bad for wound healing. We need moist wound healing because moisture allows cells to march across the wound bed and close the wound. And so if the wound is too dry, you'll see that your dressing sticks to it, it's painful, and a scab will develop. We used to think that scabs were a good thing, right? And then sometimes as kids, we would even pick at the scab, but we now know that scabs are not a good thing. It means the wound is too dry, and it actually will prolong wound healing. So in that case, you need to choose a dressing that will donate moisture to the site. So we have several options, including hydrogel, Zeroform, petrolatum gauze. Some of these dressings may or may not be available where you are, but here in the United States, these are typically what are used to maintain moist wound healing for a wound that's on the dry side. We want no trauma, we want no drama, right? So we don't want a dressing that causes pain for a patient. If it's painful when you take it off, the wound is probably too dry, and you need to look into moist wound healing. Okay, so next we talk about managing dead space. So in wound healing, we know that we have to manage dead space because if we allow fluid to collect in dead space, this can cause an abscess with time. And so there are several ways in which we do that, and that includes something called wound packing. I think everyone is familiar with orders for packing a wound. So you might see packing strips or Kerlix, rolled gauze used for that purpose. Here in the United States, we have alginate ropes, all serving that purpose. The thing about it is that people tend to go a bit crazy with wound packing. So we'll talk about that in a minute. Here in the United States also, we have advanced wound therapy called negative pressure, which is used to address dead space and promote granulation tissue. So some tips for managing dead space include: know the depth of what you're packing, okay? You don't want to pack blind pockets. You need to have depth, and you need to know what it is and where you're going to. Do not overpack. If you overpack a wound, you cause vasoconstriction. So it should be loosely packed. And also, I can't stress this enough, use one long continuous piece. We have had situations here in the United States, and I'm sure this happens all over the world, where there is foreign material left behind because multiple pieces of material were used, and that is not good practice. And then lastly, avoid materials that fragment or break apart. It needs to have a high tensile strength so that it can be safely removed from a wound when the time calls for it. Okay, and then we have opened wound margins. So if you look at this picture here, we see that this is what this is what good looks like. The wound margins are flush or level with the wound. When this happens, it allows cells to march across the wound bed and close. The problem becomes when we no longer have open wound margins. So if you look at the picture on your screen, you'll see that this patient has a diabetic ulcer, but they have a callus that is formed around it. Everyone see that? And that typically happens because of pressure that's being applied to this wound, which is a no-no in diabetic foot care. And so a callus develops in response. When that happens, it tells a wound prematurely that it is healed. The cells hit this wall and say, oh, okay, so we don't need to march across the wound bed to help close it. It's already closed. And that is because of the callus that has formed and essentially told the wound, has essentially told the cells that their work is done, okay? For that reason, when we see a patient with a callus, we will do what's called paring, which is shaving it down. And this is done over a series of sessions because this prevents wound healing as well. We need to have open wound margins so that the cells can march across and close the wound. Some other issues associated with wound margins include something called epibole. So if you look to the left, you see this wound here, and the wound margins look almost as if they're tucked in. I don't know if everyone can see that very well, but it looks like it's tucked in. And when that happens, again, it tells the wound prematurely that it's healed, even though it is not. And so that also can be addressed with debridement. It opens up the wound margins, allowing for cells to migrate across the wound, provided you have a moist wound healing environment. Okay, so some tips to promote open wound margins include moist wound healing, debridement, and adequately addressing dead space within a wound. So in summary, we've talked about why etiology matters. You can't solve a problem if you don't know what's causing it to begin with. And this is so true in wound care, especially since our patients are having multiple comorbidities. It is important to narrow down what is happening with your patient. We also discussed the wound healing cascade and why wounds are chronic. They're chronic because they are stuck in the wound healing cascade. They never have a chance to get out of it. And most times a wound is stuck in the inflammation phase, which should only last for about 5-6 days or so, but instead can last for weeks to months and even years. And then we talked about components of good wound management strategies, including the need to clean and debride a wound, manage infection, biofilm, moist healing, insulation, protection from trauma, managing our dead space, and lastly, having open wound margins, allowing for cells to march across and ultimately close the wound. And so with that, I thank you for your time. I hope that this was informative. I hope you'll take a look at your patients with wounds, take a look at them a little differently with some of the tips and information that was covered today. Thank you.
Hey, thank you so much, Yvette. I don't know about you, but I learned so much. One of the things that stuck out to me was that you said we should not use hydrogen peroxide on wounds.
And I knew that that would stick out to everyone more than anything else in this presentation.
Yes.
I understand that hydrogen peroxide is cheap. It has been around for ages. And it's just something we use, that foaming action, just something about it, right? But there's been a lot of research done in wound care, and hydrogen peroxide has been found to be quite toxic to healthy tissue. For that reason, we do not use it in wound care. I'm not saying that it's not used in medicine. There are select instances, for instance, for oral care, some dentists will recommend it. Or if you have a patient with pins, we might use hydrogen peroxide solution to clean around the pins to remove a hardened scab exudate. But as it relates to managing an open wound, no.
Great. Well, thank you. And so there are questions in the chat. We have Q&A. So if you have a question, feel free to put it in the Q&A so we can pose a question to our wonderful speaker. Yvette, I don't know if you're seeing the comments in the chat. People are saying, thank you, very informative. It's just so wonderful to see a Ghanaian nurse who has really excelled in this space and is established as a leader in wound management. So thank you so much for sharing your expertise. So I see a question in the chat for you, and please keep them coming. So Benjamin Tichy asked, how do you manage an anal fistula wound? I didn't know if you've had experience with that and can speak to that. He's asking about management of an anal fistula wound.
Yeah, so an anal fistulas in general normally require some surgical intervention. So the fistulas I'm most familiar with are abdominal fistulas, so related to bowel. And a lot of the times we will manage it very conservatively until the patient can get surgery. Normally it involves correcting it with some type of mesh material. We and again, I'm sorry to not focus on anal fistulas as much, but as it relates to the concept is the same. So as it relates to abdominal fistulas, we try to make sure that this patient doesn't have a lot of output, because the more output they have, the more likely it is that that fistula will remain open. And so we will monitor how much output is being produced, and normally we'll pouch it so that we can contain the fistula effluent until they're eligible for surgery. So probably, I don't know if you're having a situation where you're doing some kind of localized wound care, where they may be asking you to do some kind of cleansing or packing, but ultimately surgery is the way to go. The person would need to have surgery for this to be repaired.
Okay.
Yes, sometimes these injuries occur during childbirth, where the person will develop very unpleasant fistulas where they have stool passing from the vagina, and very unpleasant. And again, those patients, they ultimately they need to have surgery to have any quality of life.
Right. Oh, thank you so much. So there's also a question about this question is from Isifu. Winnie is asking, is it okay to use honey on chronic wound? I know you mentioned honey earlier, so is it okay to just go to the market, buy honey, and put it on a chronic wound too?
That's an excellent question. And the answer is no. So the honey we use here, at least in the United States, is medical grade honey. So it's been treated in some way. Normally it's a grade, there's a honey called Manuka honey, which is known for its highly healing properties. They even have it in skincare products because it is known to be very effective against bacterial infections. And so the honey that we use is treated in such a way that we can use it. So I would not recommend going to the market to buy honey for wound management. Unfortunately, it has to be something that has been treated. And by the way, maggots are also used for management of necrotic tissue as well. It is not very popular here in the United States for good reason. Most patients would scream at the thought of having maggots being placed on the wound. But those maggots are medically grown maggots. They are not the maggots that just kind of crawl around. No, they have companies in the United States that actually will harvest maggots in a sterile environment and use it for wound care.
Right. No, thank you. And I see a lot of questions coming through, so I'm going to try to get to them. And I see hand raised as well. So I'm not sure if I can allow people to speak. So Rose, let's start with Rose. Rose, do you want to unmute and ask your question? Rose, are you there? Can you unmute and ask your question? Okay, I think Rose is not ready. Let's move on to Atiga Awini. Do you want to unmute, ask a question? Yes, go ahead.
Yeah, good. Thank you very much, madam. I'm speaking from Upper East region, Ghana. There are instances that we've been using metro taps on wet wounds. We always grind it, then put on the wet wound. Then what it does is that for some days we realize that the slush on the wound always goes out. I don't know if that practice is acceptable. Thank you.
Sorry, what is the name of the item you are putting?
Metro taps Metronidazole 200 milligrams tabs.
Oh,
The tabs, the yellow one.
the flagell.
We
So
do,
flagell.
we do grind it,
Yes,
then put it on a wet wound.
yes,
So continuously, we realize that the slush that comes on would wear off. Then
yes,
the wound becomes clean.
yes.
Then the healing takes place. I don't know if that procedure is still advisable and if it's good for us to continue.
Uh-huh. Okay, so metronidazole, so also known as flagell tablets that have been crushed. We do that here in the United States also. So we will normally do that for wounds that's having odor to help manage the odor and reduce infection. So yes, we do that here in the United States. That can be effective as well.
Great, thank you so much. I see another hand. So Dr. Pao, okay, now you should be able to talk. Thank you.
Hi, everyone. Yvette, this is a wonderful, very, very knowledgeable topic, and I really enjoyed the session. Just want to touch base on the anal fistula. So anal fistulas are very, very, very complex, and the etiology sometimes is from people with inflammatory conditions. And usually what happens is there's a leakage or there's a pathway between the rectum quite normally, that kind of goes through the tissue, the muscle, and all the way to the anal. So if you come across any wound across the anorectal region, it's very, very, very important that these patients do have scans to identify, because quite often there's a tracking all the way to the colon, and that means the patient will need a surgical fistulectomy. Just ordinary dressing and stuff won't really heal that. And also just to touch base on the peroxide and then the betadine. So these also have been known to be carcinogenic as well. So and also for Ghana, gentian violet. Gentian violet, I know it's still used in Ghana. That's also carcinogenic. That's also carcinogenic. So we need to avoid these old wound dressings. So thank you very much, and that was excellent presentation.
Thank you so much, Daniel. You know, it's interesting. Gentian violet, there is a dressing in the United States called Hydrophora Blue. And gentian violet is actually the main ingredient in that. And we actually use it very often. And podiatrists tend to use gentian violet. They just love it. They just love it. They'll use it, for instance, if you have a wound with maceration, meaning the wound margins are wet because the wound is draining heavily. Sometimes they will put it on the peri-wound skin for management. But you're right. You have to be careful with gentian violet because of its side effects. So thank you for that. And also, earlier in my presentation, I mentioned the need to, when you are packing dead space, you need to know where you're packing to. There have been times where you have a wound, pressure ulcer to the sacrum, and then you having this fluid, straw-like fluid being produced. Where is it coming from? What is happening here? So imaging is also very important to know what you're dealing with. So absolutely good point.
Great, thank you so much. So there are more questions. This is a very popular topic. I see Eunice Aidoo asked, growing up, our parents use hot water for wounds. Is there any clinical significance? I've seen not just hot water, hot stone, just growing up. I remember one of my nephews, injured himself, and, they got a hot stone, put it in the fire and put it on the wound. So can you speak to some of, yes, it sounds painful. I'm sure it was. So can you speak to the practice of maybe using hot water on wounds and hot stones and other similar practices?
Well, I think I can say this confidently that hot stones may not be a good idea. Anything that causes pain and trauma will just not be the best choice at all. So I've never done it. I wouldn't recommend it. Now, in the United States, we do sometimes use tap water. So here in the United States, the water is treated. So we'll tell a patient, okay, you take a shower, soap and water, and allow the water to be running across the wound before we do wound care. So that is common practice. We do that. But the water has to be treated, okay? So if you are maybe making a solution of normal saline, you can make that. Dakins, which is dilute bleach, can also be made at home. Acetic acid, which is a vinegar solution, can also be made at home. However, you have to boil the water first. There are recipes online for these solutions, and they're quite effective at treating infection. So the water should be treated first,
Right,
before you mix it with other solutions in order to get the desired effect.
great, thank you. So I think we have time for 2 more questions. Someone's asking, please, is it advisable to dress a wound healing with first intention with bovidine iodine? I think they're asking if you can dress a wound that's healing with bovidone iodine.
So betadine, yes, that's known as betadine here in the United States. Betadine has very select uses. For instance, you might have a patient who's a diabetic, who's a smoker, they do an amputation, and they have a wound that is opened up. Sometimes surgeons will use betadine dressings until the patient maybe can get surgically evaluated for circulation. A lot of times these patients also have bad circulation. And so they know the wound won't do well until they are revascularized. In the interim, they may recommend betadine dressings for the wound just to keep it from being infected. Or, as I mentioned before, we'll use betadine to paint dry, intact eschar to the heel, because we do not want to disturb eschar. When it comes to it being on the heel, it serves as a protective barrier. And some clinicians will use betadine to paint it just to keep it dry. Otherwise, for routine wound care, no, because betadine prohibits cells from growing. It harms fibroblasts, which are responsible for promoting granulation tissue in a wound. That is why we do not recommend betadine for routine wound care, especially a healthy granulating wound. No.
Wonderful, thank you. So the last question before we wrap up, someone's very curious why you chose to specialize in wound care and management. Can you share with us why you chose this path?
I know this says something about me. For sure, there's something wrong with me, maybe, but early in my career, I worked with the geriatric population, and they had these terrible pressure ulcers. I couldn't believe what was happening. And what I learned in nursing school was so basic: wet to dry, normal saline, and that's it. But I realized that that was not solving problems. It wasn't. And so it really made me curious, and it made me decide very early in my nursing career that wound care was something I wanted to do. And there's an organization called the Wound Ostomy Continence Nursing Society that I am a part of. And they are the ones who offer the board certification. And from there, I mean, it's just been so wonderful, my career in wound care. It's really an interesting field. Now technology is playing a role in how we manage wounds. So it's a very diverse field. You'll treat across all disease states. It will give you a great background in everything from nephrology to diabetes to cardiovascular diseases. And so it just challenges you in that way. And that's why I chose it.
Wonderful. Well, I think that's all the time we have for questions. I don't know about you, like I said, I've learned so much. Let's take a moment to give our presenter a round of applause for her taking time to really share her expertise with us. And I don't know if you have that reaction option, but a round of applause. Thank you so much. Yes, thank you, Evelyn. Thank you so much, Yvette. I think the media team wants to get a photo of you smiling, and you smile throughout. If you can take down the screen, or maybe go to the first slide, and I will hide my face, but you're the star. And so thank you so much, everyone. Thank you for to our attendees for joining us today. This is going to be one of many webinars in 2024. Please stay connected. If you're not a member, please join GDNA. We have more content like this. People have been asking for the slides. We're going to post the content on our YouTube so you can share with all your friends and colleagues. But thank you so much. So I'm going to turn off my camera, and Yvette, if you can smile for our communications team, I think they want to get a photo of you. Thank you, everyone. Take care.
Okay, thank you all so much. I really enjoyed it.
Okay. Jackie, I think you should have gotten what you need, but thank you so much, everyone. Okay, great. Take care, everyone. Bye.
Bye-bye.